Okay, once again, welcome everyone. So our today's session is about MRCPCH clinical exam orientation, especially those who joined new in our batches, and also those doctors who just passed AKP in May 2023. For them, it will be a very good orientation session. So before I start, do anyone have any question to ask, especially the AKP past candidate? Anyone has any question to ask about the orientation? What will be the system? Or we will directly go to the session. Okay. So as you all know me, I'm Dr. Tamanna Yasmin, MRCPCH course coordinator. So our course is divided into theory and clinical exam. I'm not going in that discussion. Just let us see what is our agenda today. So our agenda today, introduction about the management of stations, how you will take preparation, how many months you needed, and stations, timing of the orientation, mark distribution, preparation time, what are the books and what are the resources needed. Okay, this is about today's meeting. At any point, if you have any question, you can ask me. Just raise your hand and I will give you the floor. All right. So let's start. Bismillahirrahmanirrahim. So this is the flow chart for MRCPCH clinical. You can see the flow chart here. Let me just minimize it. Yeah. Okay. So you can see the flow chart here. MRCPCH clinical exam circuit. This is our exam circuit. Until now, the timings are all right. I mean, this circuit is the most appropriate circuit. So at any point, you can start your exam. I mean, not every student will start from station 1. Some student will start from station 4. Some student will start from history taking. Some student will start from video session, okay? Okay, Dr. Barakatullah has some question. Okay, Dr. Barakatullah, I will give you floor. Just let me finish this flow chart, okay? So first of all, this flow chart, you have to see the flow chart very well, because before our exam, I did not know that the flow chart can be started at any point. I thought that I will start from station 1. I was prepared like that. But what happened when you prepare something and you don't understand the exam pattern in the exam circuit, then your mind become haphazard, okay? I thought that everyone starts from station 1, but actually no. Some people will start from station 1, so they will start from clinical 1, clinical 2, clinical 3, and clinical 4. Some people will start from development, okay? So they will start from station 5. Then their station will be development first station, history, then communication, then video. So this circuit will flow like this, clockwise. But some people, like suppose 24 candidate is giving exam, 8 candidate will start from clinical, 8 candidate will start from development and history, and 8 candidate will start from communication. Okay, like this. So the flow chart is very important, and you have to have a clear idea about the exam center, examiners, time distribution, okay, waiting time, who will be inside the room. If you have a very clear idea about the exam situation, then half of the work is already done. What we say in our preparation, we say that preparation is the half done. I mean, when you take preparation, your work is already half done. So if you have this circuit in your mind and you know the circuit well, then your exam is already under control, right? So anyone has any question at this point? Doctor, some doctor has question, please, you can ask now. Someone is asking me some question. Is there any question? Okay. Then, so there is one point here important is if you already know the exam circuit, then you know that development and history taking, they are the biggest station. Developmental station is 22 minutes and history taking is 22 minutes. So you know that this 22 minutes is the biggest station actually. Not big in comparison to number. Yes, number is also very big, like developmental station is 12 number and history station is 10 point. So you will get 10 number, full mark. So yes, they carry a lot of mark, but the main problem is not the marking. Main problem is the developmental station and history taking are the biggest station, 22 minute. What happens if these stations are at your first station? You have to actually, doctors, you have to ask me question, okay? Because you have to raise your hand and you have to ask me question, because when I am presenting, I can't see the chat in laptop. So you have to ask, okay? So yeah, so what I'm saying that developmental station and history taking, these are the biggest station. They carry the most mark and they are in time, they are also very high time. So if this station is your first station, then actually good. Okay, it's actually good because these stations at the beginning means you will be less tired. But suppose your station starts from communication, then the development and history will be your last station. And that is very, very tiring, because when you finish clinical 4, you will be already tired. And then you know that I have development and I have history taking to give. It's really, really exhausting, but you cannot do anything. You have to be mentally prepared that my energy, I should not spend all my energy to this 8 station. I have to give development and history as well. Yes, Dr. Ali has a question. Dr. Ali, please open your mic.
All right, thank you very much. Can you please tell me, are we allowed to take anything with us during the exam, like any stethoscope or any equipment, or we are provided with such things from the center?
Everything will be in the center, but if you take your own stethoscope, that is allowed. But carrying instrument is not allowed, other than stethoscope.
All right, thank you.
Yeah, welcome. So I have nothing to say in this circuit anymore. So then timing, I will talk to you about the timing later on. And also I will talk to you about the marking and timing in my next slide, okay? So total how many stations? We already know, total 10 stations, okay? And what about the timing of the stations? Let us discuss. So we have 4 clinical stations. 4 clinical stations, we have, each station is 6 minutes. And 6 minutes means we will examine the child 6 minutes. And then I guess this slide is very little for you. I'm trying to make it bigger. So can you see the slide, everyone? The slide is clear now?
Yes.
Okay. So there are 4 clinical stations. Each clinical station is 9 minutes. So there is 4 door, 1, 2, 3, 4, 4 door for 4 clinical station. And when you are outside, there is nothing written in the paper. Sometimes it is written severe station. Sometimes it is written abdomen station, nothing else. The name and age of the child, nothing will be given. When you enter into the station, you will hand over the mark sheet, and the examiner will tell you, she is a 5-year-old girl, please examine her abdomen. Or she is a 5-year-old girl, please examine her lower limb neurology or lower limb motor examination. So this will be your examination. So doctors, I'm requesting again, please, if you have any question, just raise your hand. I'm not chatting with you here because I can't chat now. So please raise your hand and ask your question, okay? So 6 minutes, you will examine the child. See, before you enter into the station, you don't know what is the station. So you have to enter into the station. You have to examine the child. At that moment, you have to interpret what is your sign, what is the sign, and then you have to tell the examiner. So there is no point of writing. You cannot write anything. Okay, you cannot write anything because both the hands are busy in examining the child, and there is no time, only 6 minutes. So after you finish your examination, the examiner will tell you, okay, present your case. So you will present your case. Yes, Dr. Barkatullah has question. Please ask your question. All right. So after you finish your station, the examiner will tell you that present your case. You will present your case. And after presentation, examiner will ask you a few questions. Previously, the question were only investigation and treatment. Now, RCPCH strategy has been changed a little. They are asking question related to clinical reasoning. Suppose a child of cerebral palsy developed sudden weakness. Why? Why he developed floppiness in the lower limb? It is a case of cerebral palsy. The tone should be high. The jerks should be exaggerated. Why the jerks is lost? Tone is low. Okay, so this is called clinical reasoning question. So this type of question will be asked according to your station. If it is a neuro station, they will ask you neuro related. If it is a cardiac station, they will ask you cardiac related cases. So after you finish your clinical station, examiner will say, okay, you can go now. Then you will come out, and then you will wait for the second station. This is how your 4 clinical station will run. Anyone has any question? Please, now you can ask about the clinical or anything.
Hello, assalamu alaikum. Can you hear me, ma'am?
Yes, I can hear you now.
I have a doubt. How many years, for example, I passed first FOP, then after 1 year I wrote TAS, then after 1 year I wrote AKP, both papers. Now I passed almost, it took me almost AKP, I finished 2 years before. And from then continuously I'm applying for clinical. Till now, 6 times I applied, they did not give me anywhere. They are telling a lot of people waiting before. So how much time I have left?
I personally applied 14th time, then I got a seat.
No, no, but I want to know, they told some 7 years, which the 7 years starts from where?
7 year starts from your last theory exam. So you passed theory last 2 years back, right?
AKP, yes. So I have still 5 years left.
Yes, yes.
Okay, thank you, madam. Okay, thank you
very much. Yeah. Okay, any other question? Anyone has any other question? All right. So after 4 clinical stations, suppose there is a development. Now, I'm not saying everyone will start from 4 clinical. No, I said the circuit can be start from any point. But if you finish 4 clinical, then after 4 clinical, you will be development. Okay. Development, you will wait outside the room. There will be a question paper that this is a 3-year-old child, 3-year-old boy. His name is Jimmy or Jack. Mother has concern that Jack cannot walk. Please take history from mom and do the assessment of Jack for gross motor or only motor examination, othoba gross motor, othoba fine motor, anything. So this will be written outside the exam hall. Then you will enter into the room, and then examiner will tell you, this is the mom of Jack. Please talk to her. Your time is start now. So examiner will not talk to you anything in this 9 minutes. So previously there was 13-minute history, okay? Now it is changed. Now the history time is total 9 minutes. So the history time has been reduced now. Now the history is total 9 minutes. So at 6 minutes, there will be a knock at the door. And examiner will tell that, proceed, you have 3 minutes left. And then after 3 minutes, examiner will tell you, please stop taking history. And then the role player or the mother will go out of the room. Then examiner will say, please present your case. Then you will present that today I have taken history from Jack's mom. Jack is a 3-year-old boy. And whatever history you took, then the examiner will say you, okay, so what is your diagnosis? Either it is global developmental delay, or it is gross motor developmental delay, or anything, speech delay, anything. Then your assessment portion will start. So examiner will ask you, okay, come here now, do the assessment. So you will start your assessment. Then during assessment portion, it is increased. Previously, the assessment was 6 minutes for motor, gross motor, fine motor. Now the assessment is total 9 minutes. So the assessment portion has been increased. History portion decreased and assessment portion increased. So assessment is 9 minutes. Then after assessment, the examiner will be the child. I mean, there will be no child in developmental station. Before COVID, actually, there was patient for development like autism child, or Down syndrome, Turner syndrome, tuberous sclerosis. Before COVID, there were patient. But after COVID, this developmental station has no patient. Okay. All the station has patient except the developmental station. So the examiner will tell you that, suppose I am the child, you can talk to the child as if I am the child. Okay, you can talk to me. Then you have to act as you are seeing a child. You have to act like that. Okay. So you will be talking with the examiner, but as a child. Suppose, Jack, can you tell me what is your name? My name is Tamanna. What is your name? Or can you run for me? Can you walk for me? Like that. Examiner will say, he is walking like a duck, or he cannot walk, like that. Examiner will say the finding of the child. Okay. So that is 9 minutes. So this has been changed. Previously, it was 6 minutes. Now it is 9 minutes. This has been changed. So then after 9 minutes, your station is finished. Then examiner will tell you, okay, so present your assessment. Now you will not present your history, because history portion you already assessed. History portion you already finished. Now you will talk, what is your assessment? What you found in this child? Like, is it a gross motor delay you found, or fine motor delay you found, or global developmental delay you found? So you will present your case. Then the examiner will ask you few questions like, why you think this child has delay? This question is the most common question. Why you think this child has delay? Then after that, the examiner will tell you, okay, then tell me, what is the investigation you will do? And how will you manage this patient? Now there are some tricky points in management of the developmental station. This management is not only like, I will refer to cardiologist, I will refer to genetist. No, there are different managements and very tricky managements. Some patient does not require any referral. I mean, only developmental pediatrician. They do not require physiotherapy. They do not require occupational therapy. That reassurance. They will give you a normal child sometime. And that time, if you say the examiner, I will refer to the multidisciplinary team. Among them, there are 15 members, but the child is normal. His development is normal. There is no red flag. That will be a blunder, right? So you have to know what is the red flag of development. You have to know that, shall I refer this child? Is the child really needed a referral or not? Okay, is he having some issues or not? Is this a normal development, or is it a developmental delay, or is it a developmental regression? Sometimes they will give you a regression child like Rett syndrome or neurodegenerative disease. Those children need urgent referral to neurologist. Now, in this case, if you say, I will refer to multidisciplinary team, among them pediatric, developmental pediatrician, neurologist, all will be there. That is actually a wrong answer, because sometimes the children present with acute complication and you need to urgently admit the child or urgently refer the child. Okay. So this is the tricky part, that management, we think that management means multidisciplinary, very easy, 15 member, very easy. But you have to understand the motive of the examiner, motive of this examination, that you can pick up the red flag, you can pick up this child needs hospital admission or not, you can pick up that this is a normal development, we only reassure the parent, there is no intervention needed for this child. Okay. So this is the management planning. This is not only for developmental management. This is also for history management. Suppose your patient is history taking, then also your management will depend on this. Okay, that how are you managing the patient? Are you referring to 15 doctors, or are you referring to only the appropriate doctors? Okay, so this is the management portion in development. Any question, anyone? All right. Then after the development, suppose your history taking station will start. So same, you will be given a question paper outside the exam hall, and the question paper will tell you that this is a 13-year-old teenager, talk to his mom about recently uncontrolled diabetes. Okay, so he is a known case of diabetes mellitus patient, diabetes mellitus type 1, obviously. Recently, his diabetes got uncontrolled. Please talk to her or his mom. Now, you have to understand whom I am talking with. Some candidate did this mistake. They thought they have to talk with the teenager. And there was a woman inside the room, and the candidate got puzzled. Is it the teenager or the mother? Because during exam stress, you will forget that what was written in the exam paper. You will just forget. Okay. So that is why you have to understand that whom I am talking with. Particularly, this is important in communication scenario and in history taking. Who is the person inside the room that I am talking with? Okay, this is very, very important point. You have to remember this in mind. So, history taking, it will start. The question outside the room, it will be very minimum information, not like they will give you very lot of information. No, they will give you a very minimum information, like information about diabetes mellitus. Please take history. So don't expect there will be a lot of information, because history taking means you have to explore the cause. Okay, much information if they already gave you, then there is no point of history taking, right? So then the question paper will be outside the room, and you will read the question paper 3 minutes. In this 3 minutes, I usually teach my students what to do in this 3 minutes. In this 3 minutes, you should prepare that who is there inside. Okay, it is mom. Then you should prepare that, okay, what is the agenda? What is the diagnosis? Type 1 diabetes mellitus. What is the problem? Recently uncontrolled. Now you have to search the uncontrolled diabetes mellitus. Is it hyper or is it hypo? Because the cause is totally different. Hyper is different cause, hypo is different cause. Then a good student will do what they will do. They will write down 4 or 5 causes of hyper and 4 or 5 causes of hypoglycemia in a paper, because there is a paper, pen and paper, you can write down. So that makes your DD more appropriate. So before you enter into the station, you don't know anything. You don't know about the child, you don't know nothing. But in your mind, there are some cause that you write down. These are the causes of hyperglycemia in a teenager. Then when you enter into the room, you saw there is a mother, and then you greet appropriately to the mother and the examiner. Your body language, your greeting is very important. Remember, as soon as you enter into the room, the examination is actually started. Okay. So when you enter into the room, you greet the examiner, you greet the mother, and you sit appropriately. Your position of sitting, your posture, your hand movement, your eye contact with the mother is very, very important. So you are starting history. The examiner will say, okay, start your history. Then you will start your history, onset, how it is started, when it is started, how you noticed that his diabetes is uncontrolled, since when you noticed, like that. Then it will, after 9 minutes, there will be a knock at the door. That means you have 4 minutes left. So 9 plus 4 is 13 minutes. Total history is 13 minutes. So you have 4 minutes left. At 13 minutes, there will be a final bell. Examiner will tell you, please stop taking history. Then and then you have to stop taking history, because if you continue taking history, then it will be like cheating. Examiner will downgrade your mark, maybe fail you, because suppose you remember some important point, social history, you did not ask social history, and then the bell rang, and then you started history. Okay, how many family members you have? Then examiner has the capacity to fail you, because when the 13 minutes is gone, you cannot say any word other than thank you. You just say thank you. Okay. Even if you did not take social history, that doesn't make you fail. But if you talk after bell rang, that will make you fail. So after this 13 minutes gone, door will open and the mother or the patient will go. And then the examiner will tell you, okay, present your history. Then you will present whatever history you took. That today I took history from mother of Jack, who is a 13-year-old boy, presented with uncontrolled diabetes mellitus. And on history taking, I found this. And then examiner will tell you first thing, okay, what is your differential diagnosis of uncontrolled diabetes mellitus? Then better to say 4 or 5 differential diagnoses. Now, sometimes there will not be 4 or 5 differential diagnoses. Sometimes there will be like 2 differential diagnoses. That's okay. That's not like, it is not mandatory that you have to say 4 or 5 differential diagnoses. But usually in MRCPCH clinical, they will give you a complex case. They will not give you just that he is not taking insulin, that's why his diabetes is uncontrolled. No. They will give you puberty-related cause. They will give you anorexia nervosa-related cause. They will give you Addison's disease, hypothyroidism, celiac disease, cystic fibrosis, like this. So they will give you a complex patient. So your differential diagnosis will be high. It will be like 4 or 5 differential diagnoses. And most importantly, many people think about differential, about non-accidental injury, child abuse. Many people think about those. So keep in mind about non-accidental injury, child abuse. But usually in a teenager, non-accidental child abuse, we don't think. Okay, it is very rare. So this will be your history taking. Then the examiner will slowly proceed. So remember, in history taking, the question answer session is almost 9 minutes. 13 minutes plus 22 minutes. So total 9 minute history, only question and answer. It is the biggest session actually, because examiner will judge your knowledge about management of diabetes and a young person, how far you know. Examiner will ask you each and every point, like the pathophysiology of diabetes mellitus, what is the relation of diabetes mellitus and celiac disease, how will you investigate this child, how will you manage this child, which team you refer, okay, how can you improve the lifestyle of this child psychologically, support, will you give or not, will you refer this child to the support group of diabetes or not. These things matters in UK exam. The candidates who pass FCPS or MD from Asian countries, they have very lack of knowledge about this management portion, that a management of a child does not mean only I'm giving treatment. Management of a child means treatment of the child and treatment of the family, both physically and psycho-socially. So you have to give holistic management, whole management, not only medical treatment, not only surgical treatment. You just refer to medical specialty, surgical specialty, no. You have to give referral to youth team, like youth offending team, or support group. Yes, I can see someone has any question. Please open your mic and ask your question.
Yes, you have mentioned the examiner signal to examiner at 9 minutes and 19 minutes signal, but he is present from the start of the station or he enters at 13 minutes.
No, examiner will see you how you are taking history, because that is also examiner is giving you mark.
Okay.
There is two marking in development in history. One marking is examiner is seeing you how you are taking history. That is the marking. Another marking is question answer. So suppose history mark is 10 number, 5 number is for history taking and 5 number is for answering. So even if you can't answer appropriately, but you already did history and you took very good history, your differentials are very good, examiner is bound to give you 5 mark, because the half mark is already gone for history taking and then half mark remaining for your question and answer session. So examiner will be in the hall, in the station with you from the beginning. Every station examiner will be from the beginning, even in communication, even in video. Okay. All right. Is that your answer, doctor?
Yes, and clinical also.
Yes. Otherwise, who will observe you? If the examiner is not here, who is the observer then?
Okay, thanks.
Yeah. Okay. Welcome. So, any question related to history taking? Anyone? Okay. Then, after history taking, there is a communication station. So, communication, you have to understand. Communication means, let me tell you my experience of my students, some students who admit my batch at first time. They start talking. They do not give any break. They do not ask in between, did you understand? Or is there any question? Okay. So this is not communication. Okay. This is just like a lecture, like you are taking some class. So taking class and communication is different. Communication means main point of communication is what is the concern of the patient or parent, why he is here. Okay. Let me tell you one of my patient, because I'm a community pediatrician. My patients are most complex patient in the world. Like they have multiple needs. They are neurodevelopmental delay. So they have 15, 20 problem in their body, mind, everything. So I am allotted 30 minutes to see one patient, 30 minutes. So bringing the patient, waiting, heighting, everything, 10 minutes already gone. Weight, height, measurement, hello, hi, how are you? My name is Dr. Tamanna. 10 minutes already gone. Only 20 minutes. How many questions you can ask in 20 minutes? Then you have to examine the child as well. Heart, lung, musculoskeletal, neurology, everything. So what I do, I first ask the mother, what is your main concern that brings you here today? I mean, what you expect from me after today's consultation? Then mother tell me, doctor, I want my child's educational support. He is not properly learning. His cognitive function is behind. So mother is telling the problem. So this is the appropriate communication style, that what is your main concern? So in communication, they will give you one problem. Suppose the child having meningitis, you need lumbar puncture. So before lumbar puncture, because lumbar puncture is an invasive procedure, so you need to take permission, consent. So take consent from the mother. This is a problem, right? This is a problem. So they will give you a scenario or a problem in the question paper. Please talk to Jack's mom. Jack is a 1-year-old infant. Jack has sign symptoms of meningitis. Then your consultant decided to do lumbar puncture. You are the neonatal register or pediatric register. Please take consent from Jack's mom. Now, this is your scenario. So in this scenario, what question mother can ask you? You have to be prepared before you enter into the station. What question mother will ask you? Okay. Suppose mother will ask you such a question that you never heard. You never heard. Okay. Mother will ask you, doctor, what if my child faint on the lumbar puncture table? What will you do, doctor? If my child faint during the process, because you are not giving him any sleeping medication. He's alert. What if he faint, crying? What will you do? So this type of problematic question mother will give you, because this is not actually the mother, this is a doctor, right? So she will judge you. She has a 10 to 12 question written in her paper. She will ask you one by one. Okay, not all candidates, she will not ask same question, she will change the question. Okay, for some candidate she will cry, for some candidate she will not cry, because she is not actually a role player, she's a doctor, number one. Number two, she's a very good actor or actress, so she will act like she's a mother. So then your station will start. Like, so you have to be prepared that in this communication, whom I am talking with. I'm talking with a mother, I'm talking with a father, am I talking with the child? How many person in the room? There will be an examiner who will be silent. Examiner will not talk to you anything in communication, because communication is total 9 minutes, and whole 9 minutes you will talk with the mother or with the child or with the father. No examiner question answer session, because this communication, mainly why this is included in UK exam, to see how you talk with a parent when they give you any problem, how you deal with a parent when the parent is angry, frustrated, crying. What is your situation? This is practical in UK. If any one of you work in UK now at the moment, you already know that communication is the most important skill in UK. When you go to the hospital, first day you are seeing patient. Most complaint will come for not as a doctor, like you cannot treat my patient, you don't know the dose of the drug. No, complaint will not come from that side. Complaint will come from the communication side, that you don't know how to talk with a mother. Especially for us Asians, this is the most important problem. This is the most dangerous problem. Maximum doctor got detected or complaints. Incident report has been made because of this problem. They do not know how to talk. Like, thank you. When you got any help from anyone, it can be one information that you took from any person. Say thank you. Thank you very much. And for us Asian, saying thank you is very difficult. I understand, because I'm a teacher for a long time. I understand the mentality of the students. For us, saying thank you is the most difficult part. You will die, but you will not say thank you. But in UK, you have to say this word at least 1,000 times in 8 hours. At least 1,000 times in 8 hours, because thank you to the patient, thank you to the office colleague, thank you to the janitor, thank you to the manager, thank you to the receptionist, thank you to the driver, thank you to everyone. You have to say thank you. And every moment you have to say thank you. So that's why communication style, I will say this is the most important station in MRCPCH clinical, because development, history taking, clinical video, that does not interact with the patient directly. Thank you, maybe you will say, you will not say. But in communication, most important, your manner, how you are talking with the patient. Your parent is very angry. Why did you do that, doctor? Why did you do that? And how you deal with an angry parent. Remember, the angrier the parent, more calm and polite you have to be. If you raise your voice on that angry mother, you are clear fail on that station. So this much for us, like Asian students, I will say communication is the most difficult part. I will say, not for all. Like some students of mine, they are very good. They are excellent communicators. In communication station, there is a knowledge part and there is a style part. So knowledge part is 50% important. I'll say, of course, knowledge is important. Like mother will say, doctor, my child has a PEG tube, percutaneous endoscopy gastrostomy tube. Now, doctor, if this tube come out dislodged, how I will manage this at home at night, doctor? I don't know. My home is far away from hospital. I can't come in hospital. I don't have driving license, doctor. What will I do? Then this is the knowledge part. You have to say the management. This is the mother's concern. Now, some candidate, what they do, when mother asks this question, they say, yes, you can call emergency number. Okay, you can call emergency ambulance service. And then, do you have any more question? What does it mean? It means you have no concern about mother's concern. Mother is the most worrying about the pig tube, and you just gave one simple solution, call emergency. You don't know how to manage the dislodged pig tube. That indicate your lack of knowledge, your lack of empathy. You don't know, number one. Number two, you don't know this is a worrying parent. You can't just answer in one word. You have to answer in 4 or 5 lines that, yes, I can understand how worried you are. Yes, if I were you, I would be same worried, because this is an invasive procedure, and I agree that it can lodge, it can dislodge. So in that case, I will tell you, make the area covered with a clean gauze, with a clean, do not try to push it inside the tube, because you may not be trained by them. And I will give you some helpline number of pig tube nurse. They are 24-hour available. They will tell you immediate management of this pig tube, and you may bring your child to the emergency department for emergency placement of the pig tube. Is that correct? Am I making it easy for you, mom? Yes, doctor. Thank you, doctor. This is the appropriate way of talking with a mother who is worried about the pig tube. You got my point? This is how your communication will run. Any question, anyone? Okay, if you are silent, then I will think that there is no question. But I must say, if I were you, in your situation, I had thousands of questions when I was new in MRCPCH. Okay. Yes, Dr. Barkatullah, please ask.
Yeah, thank you very much. I just want to ask you one more question. Like, after clearing all the 3 written exams, on an average basis, what is a time that any candidates is able to successfully secure a seat in the clinical part?
What is the chance?
Like, how much time does it take for any candidate to be able to successfully secure the seat in the clinical exam?
This was your first question as well, right? So there is no time limit, only 7-year limit, that within 7 years you have to pass. Usually RCPCH give seat in a seniority basis. When you are not getting slot in one country, you should apply other countries as well. UK is a very good center. Any country student can apply UK. So if you are not getting slot in, suppose you are in Oman, or you are in Nepal, or you are in Pakistan, you are not getting a slot, you can apply UK. Okay. And there are some centers which take international candidate, like Nepal, like India, they take international candidates. Okay. UK take international candidates. But other centers like Hong Kong, Malaysia and Singapore, now they are also taking international students. But previously, in COVID time, Malaysia, Singapore, Hong Kong, Saudi Arab, they were restricted. Saudi Arab and then Egypt, they were restricted for their candidate only. Now they are opening the slot. So you can apply anywhere. You can apply Oman, you can apply Egypt, you can apply Saudi Arab, you can apply India, you can apply anywhere. But which center has how many candidates waiting, that I can't say. That nobody can say. So it is your luck. Some of my students who joined 3 months back, they are giving exam now. Some of my students who joined 8 months back, they did not get slot yet. So this is a luck. You have to believe in luck as well. Okay. Any question related to this? You got your answer, right?
All right. Thank you very much.
Yes, Doctor. I think Dr. Ali has a question. Dr. Ali or Dr. Fatiha has some question.
May I ask you?
Yeah, sure.
Ma'am, what do you suggest to the students who have just passed EKP? Do they have to be ready in terms of skill, and then only we should start applying for the clinical, or should we start thinking about applying and then when we're confirmed that we got the seat for clinical, then we should start with the prep? And until we are still, here and there, that we are very new and we do not get the seat, what do you recommend us, that what should we start, how should we start prepping?
Very good question. I like actually this kind of question. So what should you do? First apply, then start preparation, or first start preparation, then apply? I'm telling one student, he messaged me on WhatsApp. He got 49 out of 82. Okay, she's not my student. She got 49. And she's expelled from the examination for next 1 year. She was crying horribly. Okay, she said, Madam, what to do? Can I appeal? I said, no, you can't appeal. Why did you sit in exam without any preparation? She got 49 out of 82. She messaged me because she knew me from my Facebook and WhatsApp and everything. So she messaged me for help, that if she mail RCPCH, will they withdraw the restriction? But RCPCH will not withdraw the restriction, because in 82, if you get 52 or less than 52, you cannot sit in next 1 year. So which one is better? Giving exam with 1,500 pound, traveling to another country, another 3,000 or 4,000 pound, total loss is 5,000 pound, and then total loss of 1 year, and then the loss of study you did already. So do you want that, or you are taking good preparation with a good guidance, appropriate guidance, who is guiding you more appropriately, that you should follow this, you should follow this, and then taking your mock, you are giving mock, how much you are prepared, and then that doctor or that teacher or that your supervisor, whoever she is or he is, he's telling you that yes, you are now ready for exam. Then you apply, start applying like 2-3 months back. Then you got a seat and you ask your supervisor or your senior that, am I ready for exam? And he or she is saying, yes, you are ready to give exam. You are just exam ready. Which one do you think is better? The first
the later one.
Yes, the later ones is the better. Even I'm telling you, not only for this exam, even a driving license exam in UK, I'm giving driving license exam, okay? I first take lesson, okay? And then I gave mock. And then my driving instructor said, you are not ready. So I postponed my exam. Okay? He said, you are not ready. Then I postponed my exam. Then I take new date. And I asked him, can I give exam now? He said, yes, you are ready now. So like that. So even a simple driving test you can't do. You can't know, are you ready or not? Then how come a clinical exam, you will give exam with some colleague who are not expert, who is seeing you, oh, you are very good. Yes, you can take history. Oh, how nicely you took history. But they have no idea how you are talking in communication. This is not the appropriate way of talking. So I don't think that, yes, some students are, of course, extra brilliant, extra talented, some students, but talent actually is 50% in this exam. Rest 50% is the technique of the exam. Okay, there are lots of re-meeting going on here and there, lots of re-meeting. Join everything and then judge yourself that, am I ready for this exam? And then book a seat, okay? Blindly booking a seat and wasting a seat. For you, another candidate will not get a seat because you sat in exam, you failed with 49 mark. Another candidate who was capable of passing, he's not getting a chance for you. So that means you are blocking a seat actually. So I think before preparation 80% complete, you should not sit on exam. I was already consultant in pediatrics when I gave MRCPCH clinical exam. Even then I gave exam after 3 years of passing AKP. Whole 3 years I was studying continuously, day and night, 8 hours, 10 hours. Then I could give exam and I passed. So you can imagine yourself that if you just pass AKP 1 month back or 2 months back, and you sit MRCPCH clinical after 1 month, how much you are ready? Are you ready? No, you are not ready. So at least I think you should give a chance of 6 months to 1 year. 6 months for the highly prepared student, 1 year for moderate student. You should give yourself 6 months to 1 year time for preparation of MRCPCH clinical. That means with a good group, not alone. You can't prepare alone in MRCPCH clinical. It's nearly impossible. You must have a good group. That group is motivating you continuously. And that group is, I'm telling you one important story. During my exam, we have a station that is MRCPCH communication station. The station was the child is nephrotic syndrome, comes in contact with a chickenpox child. Now, please call the mother. You called the mother to bring the child back because you need to give acyclovir half dose for prophylaxis because the child is immunocompromised, getting steroid. Now, one of our colleague, our candidate, exam candidate, she was crying after the exam. I said, what happened? Why are you crying? She said, why here it is written acyclovir? I know it is IVIG. I told the mom to give IVIG. Mom was saying, but doctor, nurse told me it is acyclovir. And you are saying injection, nurse told me oral. Doctor said, no, it is not oral, it is IVIG. Doctor actually declined oral acyclovir. So what happened? She asked the examiner, sir, why it is written here acyclovir? It should be IVIG, in the guideline, it is IVIG. I told her, do you know me or do you know any of our groups, MRCPCH groups, clinical groups? She said, no, doctor, I don't know you. She was from another part of the world. She doesn't have any idea about the groups and everything. She does not know that there is a new guideline in 2021 that says that varicella prophylaxis is now changed. We do not give IVIG, we give half dose of acyclovir. She was crying. She said, I have no idea when this changed, when this guideline changed. So the doctor who are asking me that when I know that I am prepared, when you know that you are prepared, that means when you are in a good group, everyone is discussing the latest update, okay? Everyone is giving you the information. Then you know that your preparation is going in a good way. Otherwise, if you are isolated, alone, studying continuously, high chance of fail. This exam is not only knowledge-based exam, because this exam needs tactic. Exam tactic is more important here. All right, I guess many of your answers. Yes, there is some another question, Dr. Janki, Dr. Sandipan. Yes.
Yeah, I have like two different questions. One is just to you answered, but in that, if like I have booked the exam, but I read on the website of RCPCH that they are giving the confirmation just 6 weeks before the exam date. So if at that time you, because of any reason, you feel I'm not ready, you can decline, like I don't want the seat.
You can.
Okay. And the another thing I read about the sponsor, I am already a consultant pediatrician from India. So do I need a sponsor or what is it?
Yeah, you need a sponsor. Because consultant pediatrician does not mean you can certify yourself. There must be some senior in your country that can certify you as a consultant pediatrician. Okay. You cannot certify
so that needs,
yourself.
yeah, that needs any person from RCPCH.
Yes, any person who has RCPCH degree, or not RCPCH degree, but any person who can certify that you are trained appropriately. You are not like a newcomer in MRCPCH or pediatrics. Because if you are a newcomer, just intern done or something, then this exam, I think, is not for you. You should at least have some house job, like 6 months or 1 year or 2 year house job training in pediatrics. Then this exam is applicable for you, actually. All right.
Yeah. Okay. Thank you.
Thank you very much. Dr. Fatiha has question. Dr. Fatiha.
Madam, for the certification of experience, if we don't get a sponsor, but we have experience certificate from an institute, is it Okay. Or do we?
Experience certificate is not needed. Only one
Okay.
sponsor, that is like your teacher or your senior or your supervisor, who has the
Yeah.
capacity to give your reference that, yes, I know her. She is having training. She's good in pediatrics, like that. I mean,
Okay.
they will not contact your supervisor unless you are doing very bad in exam. If you do very bad, then they will contact your senior or supervisor that this doctor did very bad in exam. Sometimes students are expelled from exam. So then the mail will come to your supervisor.
Okay.
Hmm. I can see some other question as well, Dr. Hin, Dr. Sandipan. Yes.
Yes, doctor. I have a one question there. I have been experience working in pediatric department for 2 years, but however, I'm now doing private. Is that possible that when I'm doing the private, I can stay right down for the clinical exam?
Yeah. Even you have no training, then also you can write. But you have to have a good supervisor who can tell the examiners that she's good in pediatrics. She done some house job or something. Okay. Formal training is not mandatory for MRCPCH.
Thank you. Thank you so much, ma'am.
All right. Any other question? Or I'll go to the next slide. So this is...
Hello, ma'am.
Yes, hello.
Hello, ma'am. Dr. Sandipan here.
Yes, hi.
Hello, ma'am. Ma'am, I just wanted to ask, I am from India. I have just passed my PG exam this year. So I wanted to know, after AKP, I have heard that there is a long gap to get a seat in India for MRCPCH clinical. So can I apply abroad, or what do you think? Does the chance of getting a seat increases in that
Yes.
case?
Yes, of course, apply abroad. No, there is no harm in applying. But as I said, before just before this line, I said that, first of all, let yourself give some time. I mean, are you prepared really for giving exam? Think yourself. Because if you get 52 or less, you cannot sit in exam for next 1 year.
Okay.
Okay. All right.
Thank you.
Thank you. Thank you very much. Okay. So this is communication station, 9 minutes. There will be no question and answer. Only you will talk with the mother. It seems very easy. Okay, I'll talk with the mother. Mother will ask me question. I will answer. No. How will you manage an angry mother? How will you manage when the mother will say, doctor, I will complain against you and your consultant? Then you'll say, okay, complain. So what? I don't care you. No, this is not the way of talking. Okay. How to manage an angry mother, how to manage a crying mother, how to manage when a mother faint on the exam hall. They will be doing that. They are so good in acting, they will faint in the exam hall. Then what will you do? Okay. So this is the tactic, this is the exam technique that you have to learn. Now, in our courses, the communication courses or history courses, I actually teach less. I actually teach them more tactics, that what you should do in this situation, what you should do in that situation. That is the importance of doing an organized preparation, taking an organized preparation. MRCPCH, I'm telling you repeatedly, 50% is knowledge, rest 50% is technique of the exam. Okay. Next is video station. So there are 2 video stations, 6 minutes each video station. Sorry, 9 minutes, 6 mark. Each video station is 6 mark, 9 minutes. In this 9 minutes, first 3 minutes, you will see the video only. I mean, examiner will not talk to you anything. Examiner will just say, please play your video. There will be a laptop. On the laptop, you will play the video for 3 minutes. Sometimes the video has sound. Maximum video has no sound. Only respiratory video has some sound, like wheeze or croup or crackles, or there is a cyanotic heart disease video that has sound, like murmur sound, like ejection systolic murmur, pansystolic murmur. So that has also sound. So only these two kind of video has sound. Otherwise, rest of the video like rash, arthritis, meningitis, convulsion, they do not have any sound. So there will be a headphone. You will listen the sound on the headphone. So this is the videos. You will see the video in 3 minutes. And then after 3 minutes, examiner will say, okay, please stop the video. The video will be automatically stopped after 3 minutes. Then examiner will ask you, okay, tell me what you see in the video. So you will tell whatever you saw. And then examiner will ask you question related to that video. Like if it is Henoch-Schönlein purpura, examiner will ask you why you think it is Henoch-Schönlein purpura, why not this is meningococcal meningitis, like this type of question, examiner will ask you. This is a very tricky part because video station depends lots of guideline and we are very reluctant to read guideline. We do not want to read guideline because guidelines are many. There is 2 guidelines now. We have Green Book of Pediatric Guideline and Green Book of Neonatal Guideline 2022. And there are at least thousands of diseases on that guideline. We do not want, but actually without guideline, you cannot pass this station. Because in video station, they will ask you each and every question related to guideline. Okay. Some question examiner will ask you that is not present in the guideline. That is not present in the guideline. So those questions are very tricky. For that, you need a good company of people that can show you that this was my exam. Examiner asked me this question. So you have to know the recall. You have to know what question examiner asked you. So this is another part, important part of this exam, that you have to know what question examiner asked in the video, in the history taking, in the development, what question examiner asked you. Okay. In the communication, there will be no question from the examiner, but there will be question from the mother. Mother will ask you, doctor, I have breast abscess. Can I feed my baby? Or doctor, I have chicken pox. Can I feed my baby? Or doctor, I am taking anti-tubercular drug. After how many days I will give breastfeeding to my baby? This is the question, and this is the knowledge part. They are judging the knowledge part. So in communication, the role player will ask you some question and you have to give appropriate answer. If you have no answer for that, you don't know the answer, you have to admit, sorry, I have no idea about this answer. I will come back to you as soon as I know this. Is that okay? So saying sorry, I don't know, this is also an exam. This will carry mark. If you are a safe doctor, you will say, sorry, I don't know this answer now. So this will give you a positive impression to the examiner that this doctor is safe. He's admitting that he doesn't know. But if you say andaj means, if you say guess by guess, that I think 6 week or I think 14 week, you can't give breast milk. Then examiner will fail you because this is the wrong information that you are giving to the mother. So that means you are 0. So communication is very easy for some student, very difficult for some student. I know some of students who failed on communication. They have lack of knowledge and as well as lack of technique. They do not know how to talk and how to express the negative thing that I don't know. Okay. So this is communication and this is video station. So any question about this clinical development, history, communication, video? Anyone has any confusion? What do you mean by domain? See this chart shows you domain. So each station has some A, B, C, D, E domain. Each station. Domain A has information gathering and information giving. Information gathering means history taking. You are taking history from the mother. Information giving means communication. You are giving some information to the mother. Physical examination, this is absent in case of history taking, but present in clinical station, physical examination part. Identification of the clinical sign, like mother is saying you, doctor, my child has headache and vomiting. Do you know headache and vomiting is related with brain tumor? This is called identification of the clinical sign. So you understand what is the clinical sign here. Then management plan planning, clinical reasoning. What do you mean by clinical reasoning question? Why this is henox-Schollén purpura? Why not this is meningococcal meningitis? This is called clinical reasoning question. You have to answer the examiner reason. Why not? Management planning, as I said, management planning should be very good management planning. Not all patients require multidisciplinary team. Some patients require multidisciplinary team. Not all patients require hospital admission. Some patients require hospital admission. Some patient you will find only need counseling and reassurance and painkiller. Suppose the patient has transient synovitis, came to you with transient synovitis. Doctor, what is the management of this condition? I will refer you multidisciplinary team. I will admit you because he has joint pain, joint swelling. No, wrong. You will get 0. Because the transient synovitis management is reassurance, painkiller, and rest. Sometimes hot compression you can give. So in MRCPCH clinical, you have to understand, is this patient needed acute management or this patient is stable? Is this patient needed multidisciplinary team or this patient need only pediatrician or only nurse? Who is the most important person that can help him? Referring to 15 doctor, referring to 15 specialty, that means you know nothing. You don't know where to refer. Am I right? So management planning that carry marks. Then communication skill, as I said, verbal and non-verbal. What do you mean by verbal and non-verbal? Verbal means you are talking with a patient. This is verbal. Non-verbal means your body language, your gesture, your posture, your hand movement, your neck movement, everything. Are you showing empathy? Suppose there is a brain death. You have to give the breaking bad news, brain death. And you are saying the mother, nice to meet you. Is this the appropriate way? This is a good line, nice to meet you. But do you think this is the moment to say now, nice to meet you? Is it really a nice time to meet the parent, to give a breaking bad news that your child is dead? So be very careful about your language, that your language can hurt other people. If you cannot make happy to some people, at least don't hurt some people. Like in our groups, you can see sometimes some people are attacking with the teachers or with the people. They like to hurt others. Okay. My question is, what will you get by hurting others? Will you get benefit? No, you will not get benefit. So hurting other people by your comments, by your phrases, by your language is very bad idea. Actually, this habit does not go. They will carry it to the UK and then they will give it to the patients. And then the complaint will be arise. They will lose their job, lose their money. So try to make a good habit that I will not hurt anyone unnecessarily, even with necessarily. Even with necessity, I'll not hurt. I'll just stop. Okay. I'll just come out. I'll not hurt anyone. So the comments is very dangerous. So be very careful in your comments in exam. Some candidates message me after expelled from examination that Tamanna, examiner expelled me because I said the mother that, why did not you give vaccine to your child? There was one mother who said, doctor, I did not give vaccine to my child because vaccine causes autism. And the candidate said, why did not you give vaccine to the mother, to the child? Do you know this is a crime, not giving vaccine to your child? Your child can die. And the mother started crying. Okay. And then complaint arose that this is not a safe doctor because she was blaming the mother that the child can be dying due to lack of vaccination. So then the candidate actually expelled from the examination for like 2-3 years. Okay, that candidate messaged me personally that, Tamanna, what can I do now? I said, why did you tell this to the mother that the child can die without vaccination? She said, I don't know, I felt very angry. She said, I don't know, I felt very angry to the mother. So when you feel very angry to any person, that why this person is taking that much money for her coaching or her tuition or her, what is your problem? If you can't afford, be silent. What is your problem, right? So Don't hurt anyone by your comments. That is very bad habit, and that habit can carry you into the exam hall. This habit will not go. The people who hurt others, they will transmit this into the patients as well. And then the complaint will arise. Okay. So be very careful. What are you typing? What are you saying? Be very careful. This is very dangerous. Okay. So this is how you will get negative marking. So positive marking means always talk positive. Always talk good. Always talk positive. Then you will be good at exam hall as well. Okay. So this is about, yes, Dr. Barkatullah has some questions. Sorry, I did not notice. Yes. Dr. Aisha has some question. Dr. Barkat has some question. Yes, please ask me. Hello. Am I audible, everyone?
Hello, can you hear me?
Yes, yes, I can hear you now.
Yes, ma'am. That's what I have. I work in a hospital, a 100-bedded hospital, and for me, this letter was given by my pediatric in charge. She is a MD in Saudi board. That's the letter I have, and I worked now almost 3 years before, because during Corona, I resigned and I have to go back to India because my brother died who was taking care of my mother. And then again, I came back and joined in a private clinic in Saudi. So it's okay, sir?
Yes, yes, it's okay. Wherever you are working, give any examiner, give any senior as a referee. No problem. That is not a problem.
No, because the certificate she gave was almost 3 years old.
I don't think that will be valid now, because you need to give now. Who is your senior now?
Because now I am working in a private clinic.
Give any senior to your private clinic senior.
There is a pediatrician I can take from him. Huh?
Yes, yes, you can. Yes.
Okay. But he is also a MD pediatrics from India. Is it okay?
No problem. Yes, okay.
Okay.
Yeah. Any senior will be okay.
Madam, I have a question.
Yes, yes, doctor, please.
Ma'am, I have an experience of 4 years previously, but currently I'm unemployed, and I'm thinking I just passed my AKP. So even if I apply for clinical, at least a preparation of 6 months to 1 year, as you said, is necessary. So during this period, if I'm not working, will it affect the fact that will I be able to apply for it? The clinical exam?
It will not affect now, but it will affect later when you are applying for job. Because for a job, a GMC registration, when you apply for job, the GMC will ask you 3-year job, 3-year continuous job history.
Okay.
If you say that I have a job, I have a gap, so GMC might not agree with you for giving registration.
Okay.
So for GMC registration, you need continuously working at least 3 to 5 years last.
Last 3 to 5 years.
Yes.
And the previous 4 years won't count then?
No.
Okay.
Like suppose you are working whole your life, but last year you are not working.
Yeah.
GMC registration will be very tough.
Okay. All right.
That's why I suggest always keep working, then give exam. No problem.
All right. Thank you.
Thank you. Any
All
other?
right, Dr. Tamanna. Yes, can you hear me?
Yes, I can hear you. Yes.
Thank you very much. Well, I just want to ask one question. While we are applying for the clinical exam, can we apply to more than one centers at a time, or are we supposed to apply to a single center during one night?
Actually, if there is, you can apply multiple center, but you can't actually, because when you apply any center, your window will be showing waiting. Okay. So when you apply any center, your window is actually blocked. You will be under waiting, right? So you cannot block another area. It will not show on your window.
So is there any option on the window that we give our preference of 3 or 4 centers?
No. You have to apply one center at a time that is more suitable for you. more suitable.
Alright.
Suppose you have a center in your country, then you should apply first to your country. Then suppose you are rejected, then your window will be open. When you are rejected, that you did not get a slot, suppose you are in Saudi Arab, you did not get a slot in Saudi Arab, then you will be rejected from Saudi Arab. Then your window is open. So that time you can apply to anywhere in the world, UK, India, Pakistan, anywhere you can apply.
Normally, after how much time are we able to know that our application has been rejected?
They will mail you. Before rejection mail, you don't know actually. They will mail you after 4 to 6 weeks.
All right. All right. Thank you.
Thank you very much. So this every domain, you can see A, B, C, D, E. This every domain carries 2 marks. That's why in history taking, there is 10 marks, because history taking means 2 domain, 2 into 5, 10 mark. And in video station, 6 mark, in communication, 8 mark. This marking depends on the domain, how many domain is in your station. So if you got 2 in each domain, suppose your information gathering is good, your physical examination technique is good, your identify of clinical sign is good. I mean, every domain you got 2, that means you got the highest mark. But suppose some of the station you got 1, some of the station you got 2, that means you are borderline. But suppose most of the station you got 0 or 1, then examiner will mark you as a below standard. If you got 2 or 3 below standard mark, that means your full examination will be jeopardized. So you will get like 52 like this, and then examiner will say that you cannot sit in the exam for next 1 year. So if any candidate has a basic problem in physical examination style, suppose there is no jaundice or no clubbing, but you said there is jaundice, there is clubbing, or suppose there is liver present, but you said there is no liver. I did not find any hepatomegaly. So that means you don't know how to examine physical examination, how to do. You can't interpret the finding, so you will get 0 or you will get 1, borderline. So every domain is important. Your communication style is important. Your physical examination technique is important. Do you understand which type of murmur it is? Is it pansystolic murmur, ejection systolic murmur, continuous machinery murmur? Because examiner will not tell you this is pansystolic murmur. You will have to understand what type of murmur it is, right? So this is your skill, physical examination skill. Then identifying clinical sign, that pansystolic murmur means it is VSD or ASD. What? Pansystolic murmur means what? You have to understand that. So this is the clinical sign. You have to understand clinical sign, clinical reasoning, and then communication skill. There was one exam, a candidate was expelled from the exam because of he was making the child cry. He was giving pain to the child, and he was expelled from the examination. So comfort your patient. Do not hurt the patient. If the child has joint swelling, if the child has ascites, anything that is tender, you feel that is tender, please do not hurt the child. Very gently, very softly examine. This exam, passing this exam is important, I know, but empathy, sympathy is most important for this exam, I feel. So do not give over pressure to the child, okay? Gently examine the child. So this is very important, that rapport building with the child, like playing and talking. When you are examining the child, please play with him. That, Jack, let's have a play with me. Jack, I'll see your chest. Is that okay with you? If you feel any pain, please let me know. Okay? Playfully talk with the child. Do not give them order, like move here, move there. You will see some subcontinent video. You will see in our subcontinent video, some students, some doctor make video. Very rough handling technique. Very, very rough. You will see in the YouTube if you search. In the UK, the handling of the patient, before handling, you have to take permission. At the time of handling, you have to take permission. Opening the chart, you have to take permission. Again, closing the chart, then say thank you. These are the, different kind of style that you have to be very master of. So your patient, talking with your patient, your communication style, verbal and non-verbal skills are very, very important for this exam, okay? So this all the domain carry 2 marks, 2 into 5, so 10 marks. So as we said, the total examination mark is 82. If any candidate's behavior is unprofessional, so he can be expelled from the exam, okay? So this is the pass mark and domain. Pass mark is, I think, on 82, pass mark is 62. Okay, 62 is the pass mark. This is the distribution of mark. You can see 2 video, 9 into 2 minutes, 3 minutes each, 3 minute watch, then 6 minute question answer. Total mark is 6 into 2, 12 mark. This is the 4 clinical station. You can see 9 into 4, 6 minute exam, 3 minute question answer. So total 8 into 4. Okay. This is 1 history, 22 minutes. And this is 1 development, 22 minutes. Okay. And 2 communication, 9 into 2 minutes. Total 16 mark communication. So this is total mark distribution. And so pass mark is 62 out of 82. Okay. Any question, anyone, before I start the next? Okay. So next you see the history taking station, how you will given mark in history taking. In history taking, A1 is the information gathering, D1 is the clinical reasoning, D2 is management planning, E1 is communication, E2 is verbal. So in one history, you see how many things they are checking you. They are checking you that how sensitively you are gathering the information. Like, are you talking like a robot? Okay, what is the problem? Okay, how many days? Okay, when pain started? How pain started? Like a robot. You are talking like a robot. You are not sensitive that the mother is saying, doctor, I felt that he's dying. Then you should say, I'm really sorry about this, that it was terrible for you. I'm really sorry. So you should be sensitive in talking to the parent. You are not a robot. You are not giving a tick, 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 tick in the exam. It is a sensitive exam, okay? You should be a human. And then how can you explore the main problem, concern of the patient and parent? And then how are you talking with a differential diagnosis? Do you understand the finding of the mother saying to you? Do you understand that after each question, how you will proceed? Suppose mother is saying, my child has pain in the limb. Then do you understand that pain in the limb is associated with many diseases? So you have to ask rash, you have to ask fever. So do you understand the relative diagnosis or differential diagnosis? Then investigation, then the examiner will ask you management, investigation, treatment. So investigation, not only medical treatment, see, investigation and management should be safe, ethical. Okay, you are telling a drug that is not available in your country. Suppose for SMA, you say Zolgensma, or you said, okay, but is this the drug available in your country? First of all, you cannot say, you have to give supportive treatment, you have to give other treatment, right? So don't say any inappropriate word. Okay, management should be here, multidisciplinary team. Okay, I'll involve my neurologist, I'll involve my consultant, I'll involve pediatric nurse. Then you can say there are some rare treatment that is available now, that is Zolgensma. So there is a style of saying management, okay? And communication skill, professional attitude. Is your attitude to the mother professional or unprofessional? Are you, like, I'm giving you an example of unprofessional attitude. One candidate gave exam. He or she, I don't know, he was too close to the role player, and the role player felt very uncomfortable. He or she gone too close. You cannot go too close to a person. There should be a minimum 1 and half hand distance. 12 plus 6, 18-inch distance should be. You cannot go too close. So this is called unprofessional attitude, okay? And building rapport, like nice to meet you or thank you for coming. Then clarify your role, shared agenda. Who are you? I'm Dr. Tamanna. I'm one of the pediatric resident doctor here. So what is your role? Are you then appropriate tone and pace? You are talking too fast or you are talking too slow? Are you giving any gap in between your lines? So this is called appropriate tone and appropriate pace. So this everything matters in the exam hall. That's why when you are talking or when you are taking history or communication, there must be one person listening to you. That is your tone appropriate? Is your face movement, hand movement, everything is appropriate or not? There must be someone to teach you, to guide you, to make your mistake, to show your mistake, that this is your mistake, okay? So this is the history taking. Any question in history taking? And this is communication. We already discussed many things about communication, like information should be accurate. You cannot give wrong information. Your communication should be well structured. I'm telling you, for UK communication, there are 100 lines. Okay, I'm writing those 100 lines actually. I'm trying to write some summarized notes. So there are 100 lines. That is very helpful. Most important 100 lines for communication station in UK. Like, I'm really sorry that it happened. Okay. If I were you, I would feel the same as you are feeling. Mother is frustrated. Doctor, you gave double dose of gentamicin or triple dose of methylphenidate or a triple dose of methotrexate. Mother is furious. You have to say, I would feel same frustrated as you are feeling now. So you have to approve. You have to approve that, yes, mother is angry and that is right. She has every right to feel angry. Okay, although it is not your mistake. Okay, so there is some lines that you must say in communication, and if anyone does not know this line, he or she cannot pass this exam. This exam has a structure, some routine line that you have to say. Appropriate level of confidence. Suppose you don't know anything, even then your confidence should be good. Like, what is good confidence? You have to say the mother that, actually, I'm really sorry. At this moment, I don't know this information. I will ask my consultant, or I will ask I will see some literature, then I'll come back to you. This is also one kind of confidence, that although you don't know, but you will come back. Okay, this is okay. Everything you should not know. You are a human being. Develop appropriate rapport. Like appropriate rapport means mother is crying. You cannot say, nice to meet you. If mother is crying, you have to say, I'm really sorry that I am the person who is giving you the news that your child, after examining your child of 2 doctors, your child has no sign of life. I'm really sorry for this news. So this is the appropriate rapport. Appropriately, you have to talk to the mother. If it is a sad situation, you have to be sad. If it is a happy situation, you have to be happy, right? Then active listening skill. One of our group member messaged me that, Tamanna, I failed because examiner comment that mother was asking me something. I actually did not hear mother was asking me. So I was answering something else. Mother is asking me something else. I was answering something else. So I got failed. So appropriate listening skill. You have to listen what is other person talking to you, asking to you. Okay. And in between, you have to give a pause. Like I am telling you that, do you have any question? Do you have any question like this? So you have to give a pause appropriately so that the mother can ask you some question. And jargon. What do you mean by jargon? Jargon means medical terminology. Like if you are saying the mother that we will do elective appendicectomy or we will do elective gallbladder operation, cholecystectomy. Mother does not know what is elective and what is cholecystectomy. So you have to explain the mother. You cannot say, we will give you opioid analgesia. Mother does not understand opioid analgesia. What is this? So you have to explain each and every medical term. So this is called jargon explained. Okay. If you use continuously these medical terms, then examiner will cut your almost 2 to 3 mark. So that means 1/3 of your mark will be cut down due to use of continuous medical terminology. Then E3 is seek, identify, acknowledge, attempt of address, display natural empathy. See, this line is very important, natural empathy. Now some persons, some doctors say like, oh, I'm really sorry, but it feels so artificial. You have to feel sorry. I mean, you do not say sorry, you have to feel sorry for the mom. Okay, like I'm giving you an example. In my exam, the mom was a little angry. Mom said, do you know, doctor, I came from office. I took leave from my office to came to you because you said that it's urgent. Doctor, why it is urgent? It cannot wait until Saturday? Then you have to say, I'm really sorry that you are in a difficult position, but it is really important to call you today because your child got a contact with a chickenpox child and your child is getting steroid. So his immunity is low. So we have to give half dose of acyclovir. And we are really sorry for that we called you. So this is the appropriate way. You have to say sorry because you did something, but this is the good. This is for the goodness, betterment of the child's best interest, right? So appropriately, you have to say sorry and you have to address the concern appropriately, mother's concern. If mother is concerned about anything, you have to give a solution. If you don't have a solution, you have to say, I will come back again with the information. Okay, and display natural empathy. So when you say sorry, when you say like, if I were you, I would be same upset. Your tone should be very accurate. It should not feel like you are artificially, you are making mock or joke. It should feel like it's very natural. Okay. Next is, these are the 6 main type of communication that comes in exam, like information giving communication. There will be a teenager, you have to give information about obesity. There is breaking bad news like leukemia, lymphoma, congenital heart disease. There'll be consent like lumbar puncture, critical incident like double dose has been given, gentamicin, vancomycin. Ethical scenario like a mother is Jehovah's Witness, she doesn't want blood. And you are a doctor, you have to give blood because the child is severely pale. Now what will you do? Mother said, doctor, my child will die, but I do not want blood. But the child will really die if you don't give blood. So what will you do? This is called ethical dilemma. Then educational scenario, you have to teach the junior doctor about some situation like DKA. Junior doctor came to you, doctor, I don't know what is DKA. Please teach me DKA. Then how to talk with a junior doctor. This is, every situation is different. Every communication of these types are different. Okay. And any question, anyone? Because we are at the last part of our meeting. I almost finished. So how should you take preparation? First month. Now, suppose the AKP candidate who just passed, what should you do? You should daily read one topic from Mark Beatty or Malaysian book, any book you like, and then practice with a small group. Make a small group like 4 or 5 person. If you don't have a teacher or if you don't have a course, make your friend a small group who are very, very dedicated. Second month, keep in touch with a senior who passed the exam, who can show you, who can guide you the way of giving exam. This senior can be anyone. He can be your country senior, he can be UK senior, he can be your supervisor, anyone who has the experience of exam. Then number 3 month, need one-to-one partner. Suppose now in 3rd month you applied for exam and you are waiting. Then you need a one-to-one study partner. Suppose 1 or 2 friend you need, whom you will say that, please, I am giving you a communication. you will give me one communication and we will comment on each other's communication. He will see the clock, 6 minutes plus 3 minutes, 9-minute clock. And then he will be the role player, you will be the candidate. So this is 1-to-1 study. 4th month, you applied and you got a seat. 5th month, practice with a small group who are very dedicated, and you are daily practicing communication, video, clinical, history, development, and someone is taking your mock and you are giving mock and he's judging you or she's judging you that you did this thing wrong, you did that thing wrong. Okay. So this is how your exam should be. And it is not like a one-day thing, just click and you passed. No, it is not like that. If someone tells you he just clicked and passed, very wrong. Either they are telling you lie or they are misguiding you. This exam, trust me, I have now 3,300 students under me who passed part 1, part 2, clinical, DCH, 3,300, 3,300 students almost I have passed out. So they all know me, that how much I am doing every day, like study for exam, that which question is coming, what is new. So the new thing is that MRCPCH clinical exam is a very structured exam. It is not a haphazard exam. As I said, 100 lines in communication, those you must say to pass this communication station. Without those lines, you can't pass communication. Okay? Because examiners are fixed, their mind is fixed. They will not change their mind. So you have to know the system of the exam. Okay? So this is how you will study. So plan at least for 6 months. At least, I'm saying minimum is 6 months. Good is 6 months to 1 year preparation time. Make a small group. And it should not be self-centered. It should be like giving and taking situation. And study 8 hours per day. Mostly practice based, like 4 hours you will read book and 4 hours you will practice. What are the resources? Like I have a video channel that is MRCPCH with Tamanna YouTube channel. There are some videos because I have coaching batch also. So I can't make so many video. Nowadays it is very less amount of video. Book I used Mark Beatty, Rebecca, Clinical Secret, Khidir. These are the books available in the market, but Rebecca and Khidir are very old book. They are like 10 years, 20 years back. So better if you read new books, like Malaysian book is the new one, Secret. Mark Beatty is new one. Mark Beatty is comparatively new. So you should not read very old book. And for communication, you have to see patient info website for UK, patient info website for leaflet, like suppose pec tube leaflet, meningitis leaflet, lumbar puncture leaflet. In those leaflet, there are some question answer. So that will help you. But I'm telling you, nowadays, the examiners are changing the question. So they are not giving you the same question again and again. Like previously, there was communication scenario for lumbar puncture and meningitis. Now they are changing the scenario. Now the scenario coming that mother is worried that the child comes in contact with a meningococcal meningitis. So will you give prophylaxis or not? This is the exam question. Okay. So the pattern of communication is changing every year. So even if you read 100 scenario, 100 leaflet, it may not get common in exam. You may get a total new scenario. So be prepared for that. The total new scenario can be given in exam. Okay. Any question? We finished our class today. Or I guess this session was helpful for you. So just post in our Facebook group that if it was helpful for you, then we can conduct some more session in near future. Yes, Dr. Victoria has one question, please.
Thank you, ma'am, for the lecture. I thought I was going to have a communication scenario today.
Yes, we will do. I will give you the link.
Okay, thank you.
Okay, you like to do now or you will do a little later on? Now you can do? Okay.
Yeah, prepared for today.
Yeah. Okay. Anyone has any question? We will practice one communication now. Anyone has any more question? Okay. So Dr. Victoria Priya, this is your scenario. Let's practice one UK scenario, okay? Anyone else I promised today to give any station? Okay. So what communication you will give? Okay. So there is a UK scenario last year, 2022 exam, okay? You are a neonatal register. Talk to mom. Mom name is Jillian. The boy is 5 days old, okay? His name is Louis. The boy developed IVH. He is in mechanical ventilator, intraventricular hemorrhage. Mom is very anxious. So the baby was delivered at 28 weeks. Since then, he was in ventilator. Now, at day 5, he developed intraventricular hemorrhage. So please talk to the mom. Give the news that the child developed intraventricular hemorrhage. Okay, Dr. Victoria?
Yes, ma'am.
Okay, so take your time, 1 or 2 minutes, then we will start.
Okay, thank you, ma'am. I can start, ma'am.
Yes, Dr. Victoria, start, please.
Okay. Good day, ma'am. I'm Dr. Victoria, one of the doctors working here. Am I speaking with Jillian, mother of Louis?
Yes, can you open the cam? Is it possible?
Yes, ma'am.
Okay, thank you. Yes. Hello, doctor.
Hello, Jillian.
Yes, doctor, that's me.
Congratulations on the arrival of your baby, Louis.
Thank you.
Thank you for coming. Please, I learned that that Louis was born at 28 weeks, and since then he has been on mechanical ventilation. Am I right? And
Yes.
now we have a problem.
Yes,
Am I
doctor.
right?
Yes, doctor.
Okay.
Anything new, doctor? Anything new problem arise?
Has anyone told you about this intraventricular hemorrhage? Have you heard of it before? Like bleeding into the brain. Have you heard of this before?
What? What are you saying, doctor? My child has bleeding inside the brain? Oh my God. Nobody told me this, doctor.
Oh, Julian, I'm really sorry that you're feeling this way, and I'm really sorry that I'm the one giving you this news. But see, Louis was born at 28 weeks, and since then he has been on this in our intensive care unit on mechanical ventilation. And now we did some investigation and found out that he has developed bleeding into the brain. So, and it's called intraventricular hemorrhage, and I'm here to tell you about that. Sorry, I'm the first person informing you about this.
Doctor, is he very serious, doctor? He will die, doctor, now.
Oh, sorry, you're feeling this way. Can I offer you a glass of water? Here is tissue.
I'm fine, doctor. I'm fine. I just want to know, is he going to die?
No, no, we have a very good team. We are really trying our best to make sure that he will not die. We have the experts for this. So we're also monitoring his vital signs, his temperature, his breathing pattern, his circulation pattern, everything about him, even his oxygen saturation. And we have some babies that have similar problems, but they didn't die, but they will require long-term follow-up to make sure they don't have complications. Is that okay by you?
So, doctor, why this bleeding happened, doctor? Why bleeding started suddenly? He was premature, I understand, but why bleeding, doctor?
This is a problem with, is actually a problem with prematurity, and we are really sorry about that. It's because their vessels, their blood tubes, blood channels are quite immature. That's why they can easily break and then bleed into the brain. That's why it is like this.
Okay. So, doctor, I want to know, what is the treatment now? You do surgery and remove the blood from the brain?
We have to do some investigation, like we are doing ultrasonography, and also do CT scan to know the level. It's not all of them that require surgery. The ones that are very minimal, even when the bleeding is very small, we just observe. It will resolve on its own, but you will benefit from long-term follow-up.
Doctor, will you not give any medication to stop this bleeding? You will not give anything. You will just observe my baby.
At the moment, we'll just be monitoring him in the intensive care unit. And then we'll try to minimize any medication that will cause further bleeding for him. And we'll observe him very closely. And also we'll have to be doing serial ultrasound of the brain, call it transfrontal ultrasonography. We have to be doing it serially to make sure that the bleeding is not worsening. And we also have to monitor him closely. Am I making sense?
Yes, doctor, he will be, I mean, wheelchair bound. He will be paralyzed.
No, oh, sorry, Gillian, you are feeling this way. It's not like that. It depends on the level of the bleeding. Some of them that have very minimal bleeding, most of the time they do well. But the problem comes when the bleeding is quite extensive. Then it can affect the brain structure and then cause problem. But at the moment, from what we've seen, the Lewis own is actually quite minimal. Well, he will need long-term follow-up because prematurity and then this bleeding to the brain is a complication of giving birth to a baby that is still immature. Sorry about that, Gillian.
But doctor, I want to know, what will be the effect of this small bleeding? As you said, his bleeding is small. I want to know, what will be his future effect of this bleeding?
It actually depends on the size of the brain that is affected. So if the major part of the brain is not affected, he may actually do well. But if the major part of the brain is affected, it can affect his vision, his hearing, his speech. That's why he needs long-term follow-up so that at each visit, we'll assess his development, assess his vision, assess his hearing, assess his development. So in terms of how he's able to carry his neck, how he's able to sit and walk. So it requires long-term follow-up with the neurologist.
Okay, doctor, 6 minutes, okay, Dr. Victoria. Okay, doctor, so what is the treatment? Just you will observe, doctor, and you will not give any medication, right?
Yes, his own is quite small, so we'll just observe him and allow nature to take its course. There are some cells in the body that will help to actually mop up this bleeding, and then he may actually do well, but will require long-term follow-up. Is
Okay.
that okay, Gillian?
Okay, doctor. Okay.
Okay, today, Gillian, we've discussed about your baby, Louis, that was born at 28 weeks gestation, and he has been on mechanical ventilation since his birth. And then on day 5, he developed bleeding into the brain, which we call intraventricular hemorrhage. And it's a common complication. It's a complication of babies born prematurely. And we have also discussed with you about the possible complications that could arise. But fortunately, Gillian's own is quite reduced. We also discussed the investigations, basically the ultrasound, and then that Louis will need constant evaluation, constant observation, and long-term follow-up. So then there's also a leaflet and then useful websites that I can give you so that you learn more about this intraventricular hemorrhage, the people at risk, especially the preterm babies, the treatments that can be given, the complications, and then the follow-up that
9 minutes. 9 minutes. Okay, Dr. Victoria.
Okay, thank you, Gillian. Thanks for coming.
Thank you. Well done, Dr. Victoria. How you felt? Okay, what mistake you did? Tell me. What was the biggest mistake?
I think I forgot the treatment options, and then other multidisciplinary treatment I also didn't mention them. So then
the knowledge part is very good, Dr. Victoria. You do not have any problem in the knowledge. You know multidisciplinary team, you know developmental delay, you know some are not wheelchair bound. Your knowledge part is perfect. You know there is 4 stages of intraventricular hemorrhage, right? Inside the ventricle, then outside the ventricle, that is the most severe one. You know everything, but the thing is, the main problem is how you started your station. You said good morning or good evening, congratulations on your baby. That is very good start. I was very happy when you started. Congratulations on your new baby. Very good, perfect scenario. Then what you did? I am here to talk about the intraventricular hemorrhage of your baby. That is a brain inside, hemorrhage inside the brain. I mean, do we give this, this is a breaking bad news. Am I right or wrong?
yes, it's breaking bad news.
Do we give breaking bad news like that way? If someone give you the news like this, how will you feel? Tell me.
I forgot about attender. Yes.
You forgot attender. You forgot
Yes.
it is the right time for me to talk to you. Are you feeling okay? Because 5 day only, mother is post labor, isn't it? She's a postpartum lady. She can faint.
Yes, yes, yes.
Ask like, are you okay? Feeling okay now? How are you? This is rapport, building rapport. How are you feeling? Are you okay now? Yes, doctor, I'm okay now. So, Jillian, I'm here to discuss with you about some important health event of Louis. Jillian, do you want anyone to attend this seminar? Attend this meeting? No, doctor, my husband has gone to work. Jillian, if you don't mind, I will call a nursing staff or a midwife because you just have had your labor. You may feel weak. Okay. Then the mother said, doctor, okay, I'm fine. Then you can proceed. So this is your initial step of this communication. Then the second step is you have to say the mother, Jillian, anyone talked to you about Louis? No, doctor, no one talked to me. Okay, then I'm really sorry to tell you that after doing some scan of the brain to Louis, we found that Louis' brain has a minimum bleeding inside the fluid vesicle. It's not inside the brain. You cannot say it is brain hemorrhage. You have to say inside the fluid vesicle or inside the fluid cavity, there is a minimum bleeding. You have to give the news in a minimum way. You cannot say brain hemorrhage. This is a dangerous thing. This is a mismatch. This is a wrong information because the examiner did not tell you it is stage 4. IVH, examiner told you it is IVH, intraventricular. It can be stage 1 in the germinal matrix. It can be stage 2, right? It can be stage 3. Intraventricular is stage 3. Then stage 4 is outside the ventricle when it goes to the brain. So that is the most dangerous part, right? The child become paralyzed, wheelchair bound.
Yes.
All your breaking bad news style was not right. It was wrong, totally wrong. The postpartum mother, you did not have any sympathy. You did not have any attender. You gave the bad news just as it is a good news. I came here to tell you that your baby has brain hemorrhage. How it feels? Tell me. And if you say like, did anyone talk to you about Louis? No, doctor. What happened, doctor? Actually, I'm really sorry to give you the news that after doing some scan on the brain, we found that Louis has a minimum bleeding in the brain fluid vesicle or fluid cavity. That is very minimum in amount, although it has, I have to tell you this news. Then give a pause. Mother will cry, mother will scream, what, doctor, what are you telling, doctor? Oh my God, like this. You have to give the news in a slow pace manner, right?
Yes,
Then
ma'am.
you have to offer tissue. That you offered a tissue, you offered glass of water, but the most important thing was your breaking bad news, okay?
Yes.
Then you have to draw, like like Jillian, if you follow my picture, you have to draw the brain. And then inside the brain, there is a cavity fluid. And then there are some little blood vessel that has torn. And there is a little bleeding. Okay. Mother is saying, doctor, will you not give any treatment? You said, no, we will just observe. But basically, there is treatment. There is treatment. We will do some basic blood test. If we find in the blood test there is anything abnormal, we may give treatment. Like suppose high PT, APTT, INR, we can give injection vitamin K. Am I right?
Yes, yes.
There is no treatment, it is not right. There are some treatment. Suppose a child has bleeding disorders, suppose factor 8 deficiency, factor 9 deficiency. Will you not give factor 8, factor 9?
Yes.
Intraventricular hemorrhage does not mean it is for premature baby. It can be due to early onset hemophilia, early onset von Willebrand, early onset vitamin K deficiency, isn't it? It can be early onset platelet disorder. So yes, there are some treatment if we found some cause, but most of the children have no cause because the blood tubes are very thin of the premature baby. And when we gave this machine, they create some pressure on the brain. But without this machine, baby will not survive because baby is ventilator dependent, right? So this machine is important for his breathing, but there are some side effects like they can cause pressure inside the brain. This is the hazard of mechanical ventilation, right? They can cause. So you have to tell the mother the exact news. This is
Yes.
knowledge part. So first of all, your empathy, sympathy part, that has a problem. Now the knowledge part has a problem. Problem is deficiency. You can correct it, right? And
Yes.
then when the 6 minutes gone, you summarize. Your summarize should be less than 1 minute. It should be 30, 40 seconds, not more than that. Your summarize was more than 1 minute. That's why you did not finish the station. It was early finished because your summarize was too long. You have to listen. When you say the communication, do not give the previous news like your baby was 28 week, your baby is in these things, mother, no. Why are you telling again?
Okay.
Mother already know these things. So don't tell these things to the mother again. So say the mother that, yes, we have talked, Jillian, about your child, Louis. Louis has developed minimum bleeding inside the inside the cavity, and we are giving him best treatment as possible. We are observing and finding out the cause, and we will let you know the update of your baby. Is there anything else, Jillian, you like to talk? No, doctor. Thank you, doctor. I will talk to my husband. Okay. Okay, Jillian, if you want, I can arrange a meeting with my neonatal consultant. Yeah, this moment, of course, neonatal consultant will talk. And then I will give you some leaflets and website so that you can read more about intraventricular hemorrhage, but not at the moment when you feel comfortable. Mother is crying, just don't give mother some more literature to cry. Just say when you feel comfortable, you can read. Or you can talk to me anytime if you want. This is called opening the door. Opening the door that you can come back to us again. This is a very reassuring line that you can talk to us anytime you want. A very reassuring line for a crying parent. Okay. And lastly, say thank you for giving me the chance to talk to you. I wish speedy recovery for Luis. Isn't it? See, if your summarize was short, your leaflet things was short, then you could say this line. And it is more appropriate when you say these lines. Right?
Yes.
All right. So how you felt? How you felt? It's a
Thank
lot of
you.
improvement, isn't
Yes,
it? Yes.
yes.
Thank
Thank you
you
so
very much. Thank you very much for giving me the chance to examine you and slice you. Okay, any other person has any question? Dr. Barkatullah has any question? Any other has any question? Yes, we finished the station. So this was our group pattern of mock and everything. I hope this session was helpful for you. This is my contact number. If you need any help or any support, just ask me. Okay, I'll try maximum to help you. But sometimes time constraint, I am only concentrating on the batch because that time I have to keep alive, even if I am dying. So I have this batch you can contact, or you can post in our Facebook any query. Suppose like this type of query, like I am AKP passed, how should I proceed, or like this. Our Facebook group is very active. You can post your query in the group. All right, guys. So thank you very much for joining, and happy Eid, everyone. Eid Mubarak again. Thank you.
Thank you, ma'am.
Assalamu alaikum.
Thank you, ma'am.
Thank you.